Hi guys, my name is Maritza Torres and my presentation is on pediatric choledochal cysts. Choledochal cysts were first described by Botter and Esler in 1723 as a rare congenital disorder. They are further defined as a dilation of the common bile duct or CBD. The normal CBD measures 1 millimeter or less in neonates, 2 millimeters in infants up to 1 year of age, 4 millimeters in 1 to 10-year-olds, 6 millimeter in adolescents and young adults. In 1977, Tadani and colleagues adjusted this classification to include 5 types of choledochal cysts. They are most commonly diagnosed between the ages of 1 to 10, and they have a classical presentation which includes 3 things: jaundice, abdominal pain, and a right upper quadrant mass. The exact cause is not completely known, but it is believed that it may be due to an abnormal junction of the pancreatic duct and distal bile duct. This would allow reflux of pancreatic enzymes into the biliary tree, which would then lead to weakening of the bile duct wall, and eventually a cyst would form. There are 4 types of true choledochal cysts and one that is no longer considered a choledochal cyst, but rather its own separate disorder. Type 1 is the most common, and it is subdivided into 3 categories. 1A is cystic dilation of the extrahepatic duct. 1B is defined as focal segmental extrahepatic duct dilation. 1C is fusiform dilation of the common bile duct. Type 2 is very rare with only 2% of cases. This involves true diverticulum arising from the extrahepatic bile duct. Type 3 involves 1 to 5% of cases, and it is dilation of the extrahepatic bile duct within the duodenal wall. This is also known as a choledocholcele. Type 4 is subdivided into 2 categories. 4A is a cyst involving both intra and extrahepatic bile ducts. 4B involves multiple extrahepatic cysts. The former type 5, which is now Caroli disease, is defined as multiple intrahepatic cysts. To scan the biliary tree, we will need a 5 to 7.5 MHz curvilinear probe. In larger patients, we may use a 3.5 MHz probe for further penetration. If the patient is cooperative, we should image during suspended respiration. Sagittal and transverse images will be obtained. The proximal CBD is imaged at the porta hepatis, and it is examined with the patient in supine and in the left lateral decubitus position. The distal CBD is examined with the patient in supine and in the right posterior oblique position. The erect position may also improve visualization for the distal CBD. Color Doppler should be used to confirm that it is not a blood vessel. All in all, the CBD should be imaged from the liver to the ampulla and should be measured at its widest and followed to the thinnest portion extrahepatically. Sonographically, we will see a well-defined anechoic fluid-filled mass in the porta hepatis that is continuous with the extrahepatic bile duct. The cyst should be separate from the gallbladder, and it is also good to note that larger cysts may contain biliary sludge. Choledocholcele or choledochal cyst type 3 differs a little bit in the way that the fluid-filled mass will protrude into the walls of the duodenum. In this image here, we can see the choledochal cyst at the porta hepatis and the gallbladder located anteriorly. For choledochal cyst type 2, the images here are from a 39-year-old woman. On CT, they found these liver lesions, which were done for lower abdomen pain. Here we can see that the choledochal cyst has a stone in it, and the gallbladder is not seen in these images. For choledochal cyst type 3, there was abdomen imaging performed to evaluate a different disease in a child with scalp melanoma. A choledocholcele was found incidentally, and this MRI shows a dilated CBD and the choledochal cyst extending into the duodenal lumen. For this type 4 imaging, it was also an incidental finding on a 2.5-year-old girl. This is an intrahepatic, well-defined choledochal cyst with communication to the right hepatic duct. The patient also had a second extrahepatic cyst of the CBD, classifying this as a type 4A. These final images are of a 5-year-old boy with a history of cystic fibrosis who presented with mild transaminitis. The ultrasound here shows loculated appearing cysts and many echogenic foci throughout the hepatic parenchyma. This represents biliary ductal saculations in Caroli disease. The treatment for this depends on which type of choledochal cyst it is. For type 1, there is complete choledochal cyst excision and reconstruction of the biliary tree with hepaticojejunostomy in a Roux-en-Y fashion. Type 2, there is surgical excision. Depending on the size of the neck of the cyst at the junction with the CBD, it may be closed or with T-tube decompression of the CBD. If the cyst arises from the intrapancreatic portion of the CBD, drainage into the duodenum is a bit easier. For type 3, there is endoscopic sphincterotomy and cyst unroofing. For type 4, type 4A is the same as type 1, and 4B involves transduodenal sphincteroplasty and Roux-en-Y hepaticojejunostomy to complete this treatment. Without surgery, children have an ongoing risk of other problems. These may include biliary obstruction, infection of the ducts, jaundice, and cirrhosis. In adulthood, choledochal cysts can become cancerous if left untreated. The prognosis is very good. The results of primary cyst excision and hepaticojejunostomy are very satisfactory. There are many reported series with a long-term survival rate of close to 100%. Although this is true, there may be complications. Some of these can include calculus formation, cholangitis, pancreatitis, and there is also a risk of malignancy. Due to these long-term risks, patients need to do yearly follow-ups with a gastroenterologist or their pediatric surgeon. They may also be required to do regular blood work and imaging. Some differential diagnoses include duodenal diverticula, pancreatic cystic lesions, dilation due to impacted gallstones, cholangiocarcinoma, and biliary stricture. Thank you guys so much for watching.